Hello, Dr. Janet McMordie. How are you?
McMordie, close.
McMordie, oh my gosh, I'm so sorry.
No, don't worry about it. It's a tough one.
What a great start. How are you doing?
I'm great. How are you?
Yeah, also good. Thank you for coming on today. I'm excited for our conversation.
Thanks for having me. I'm excited too.
Yeah, so today we are here to talk about the science of pain. It is something that you as a physician have been interested in and have worked with multiple patients or clients, I suppose it depends how you phrase it, over the years. And it's a particular interest of yours as well. Is that correct?
Yeah, absolutely. I mean, my clinical practice is in sports medicine, but I usually kind of say, I don't just see athletes. I see the weekend warriors. I see people with, injuries from work, et cetera, et cetera. And then, of course, over the pandemic, when we didn't have any sports, and I was seeing a huge increase in people's pain levels and kind of wondering why that was, kind of got me interested in the last, 18 months, diving into more of the pain science and why we experience pain the way that we do.
Mm-hmm. So when you say that you've seen that during the pandemic that pain has risen, what kind of pain are you talking about?
Yeah, so it's more the chronic pain as opposed to kind of acute pain as as in, ow, I stepped on a Lego, as opposed to pain that people have had kind of over 3 months that's pretty kind of predictable. They get the same sensation over and over again and they've been dealing with it. I definitely have seen an increase in people's chronic pain levels over the pandemic, but also what seems to trigger kind of flares in people's chronic pain as well too. That seems to be changing as well, just because I think people are dealing with so much new stuff throughout the pandemic. And again, I was kind of curious. I didn't really understand originally why, and then so again that was hence my deep dive over the last 18 months into what have we learned about pain since I was in medical school, and it is quite a lot, which is exciting.
Yeah, I mean, so what's been like the most interesting or revealing part of it for you?
Oh gosh, so much. I think
big question.
We kind of we have, I think a lot of times people think of pain as this very simplistic, way of, okay, flesh is wounded, it's a flesh wound, and then the nerves send a message to your brain about the flesh wound, and then and the intensity of that message is directly related to how severe your flesh is wounded, and then the brain goes, oh, there's some bad damage there, we believe there's some bad damage, and then we feel pain. But that is so not the case at all. It seems to be more, and again, not an exact science, but there seems to be more of a, pain is more of a quote-unquote opinion, and there's a perception that, we have to go through. There's a filter of perception that our brain has to go through, and all these different factors that tune our pain, amplify it or dampen it or change its quality, again, that the brain does to allow us to perceive pain. And I say pain is an opinion. That is not my quote. That's a very famous quote from an Indian American neuroscientist who discovered this and did a lot of interesting studies on phantom limb pain. That's kind of this weird and wonderful thing in medicine. Like somebody doesn't have a hand, but they still experience pain in the hand that's no longer there. And so this, his name's Dr. Ramachandran, did a lot of interesting studies and therapies with mirrors and whatnot, where they would set up a different mirror system, and so the patient could see his unamputated hand, but it looked like the original hand that had already been amputated, and so he could move the hand and he could see and so his brain is seeing that hand and going, oh yeah, it's there, it's working, it's good, and that helped with the phantom limb pain. It's like this weird, one of the weirdest things in medicine when nobody has quite figured out what it is, but it was enough for us to say, okay, I think there's more to this.
Something's going on.
Something's going on, exactly, yeah.
Yeah, I mean, that makes sense, right? Because intuitively it seems that you would think oh, well, if my arm or my leg has to be amputated, then I'm not going to be receiving any signals from that, and so how could I possibly feel pain in something that doesn't exist, right? And yet, at the same time, it also makes sense to me that, well, the structures that you have in your brain are already set up to almost receive those sort of signals or those messages, and so they can be activated by like different mechanisms within the brain that would lead to the experience of you feeling a pain in a place that doesn't exist anymore, right?
Yeah, exactly.
Which is very strange, but it's so interesting, right? And so this doctor that you just mentioned, so when he was doing these mirror experiments, was that to kind of like trick your brain into processing information about something that isn't there, in order to kind of like resolve an issue that was there, or what was the primary reason for his research?
Yeah, so it was mainly, again, like him being, this doctor being a neuroscientist wanting to obviously help his patient. It was like, I think the goal was obviously to make this person feel better, this poor man. But again, it was also to look at, why is this happening? And it seemed to be like the mere appearance of, this man felt better because of the illusion that he was better, because he thought he was better. Right?
Yeah.
So is there power in that? And why is that the case? And like, this is one of the most like curious anecdotes in all of pain science, like in all of medicine.
Mm-hmm.
And we still don't really understand because the brain is so complex. I mean, it gives us our reality. Of course it's complex. How can pain be simple when it comes from our brain? But yeah, pain seems to be more like an opinion on our state of health rather than a response, like a reflexive response to injury. And there's so many neat studies that have been done that show very similar things. But I have like a funny anecdotal example of a patient it wasn't of mine, but gave me permission to tell the story. He thought he had experienced like massive lower bowel hemorrhage. Like looked in the toilet and there was blood everywhere, like red everywhere. And he was like, oh my gosh, like fainted. And his wife came to check on him and he woke up and he's like writhing in pain. He saw blood. He was like, she's like, where are you sore? Oh my gosh, calls 911. And, he's like everywhere. It's so sore. I'm going to die. Oh my God. And the ambulance comes to like check on him and they make sure he's okay. And he's writhing and he's in so much pain. And they look, and a really common cause of red in stool is beets, eating large amounts of beets. And that's what it was in the toilet. And so it looked like blood. Just the appearance of blood and the fear of blood was enough to have this man experience excruciating pain. And then as soon as the paramedics said, this is what it is, we think you're okay, he was like, oh, okay. And his pain was gone. So again, this like behavior, this a response to a stimulus, a perceived threat, was enough to cause immense real pain for this person. Right. So what if like your brain just keeps believing there's a threat and there isn't like a nice paramedic who can reassure you that it's beet juice, not blood, right? Like that's kind of the nature of what chronic pain can become. So it can be, I guess in psychology terms, a learned response because you learn a behavior. So yeah, fascinating. Right.
And also like once you start expecting it to be there, then there's a much higher possibility of it actually being there, some sort of placebo-like effect of, if you wake up for the last year or few months with pain in your arm, tomorrow you're probably going to wake up and think, here comes the pain, instead of being like, is there pain today? And sort of just see whether it's the case. You're more likely to be conditioned in that way to just be like, okay, well, there's going to be pain, and so I'm just going to feel it. And then you almost inevitably do, right? Like a self-fulfilling prophecy.
Absolutely. And I think like before we got on to chatting, we were talking about, the war and PTSD, and if you feel like there is, so two examples, if you feel like there should be more pain or something is going to be painful or someone's told you something will be painful, it will be. And they've done some neat studies on people who have gotten knee replacements and they were told it's going to be horrific before they went in for the knee replacement, or it's going to go great. And predictably, the people who were told it's going to be horrific and really painful experienced immense amounts of pain, had the exact same surgery. Right. The people who were told, no, it's going to be great, it's going to be fine, did much better post-operative pain-wise. But same with like the looking at veterans or people who the history of the early pain research was done on veterans from World War II, and they had less pain when they felt they were safe. And so we as humans feel that when we're confident we're safe, we've experienced less pain. So these World War II veterans experienced very little pain, like surprisingly little pain for the severity of their injuries, because they were just assumedly so glad to be off of the battlefield and were now safe.
Right.
So that ever since then, people have been trying to figure that out. It's a good question. I'm not sure. I mean, there've been some interesting studies looking at not just veterans, but like other emotions that make us feel safe, like feelings of like when you're in love. There's very good evidence showing that you experience less pain when you're in love, or you're in a, or say children who are in a safe, stable home environment experience less chronic pain when they don't have, threats of trauma and abuse and stuff like that. I would say it probably does last because we see the flip opposite. So people who don't feel safe, especially children who've been exposed to high levels of adverse childhood experiences like abuse, incarcerated parents, et cetera, we see throughout the rest of their life they're impacted by that. So I wouldn't be surprised if the opposite was true.
Right. Or at least, it would last as long as that feeling of safety persists, right?
Yeah.
Like there might be a period of time where the relief from being off the battlefield and being at home gives that sense of safety, but sort of like as life goes on, things might change for a given individual, and then old things might start coming up again, right? But I'm interested in this idea of pain being an opinion, and I think what I take from you saying that, because I've never heard it phrased like that before, and are you saying it's like a perception in a sense of like it's quite individualized to you and how you're interpreting and perceiving these sensations that are happening in the body, right? Because pain itself is a very broad umbrella, and there's so many different kinds of pain. Even just from like a physical pain perspective, it can be like sharp pain, burning pain, like long pain. I mean, I don't know, cramping, all kinds of things can happen, right? And then it's a matter of like, well, you experience this pain or this sensation, let's say, and then a part of your brain goes, well, what does this mean, right? And how can I understand and interpret what's happening right now? And is that what you mean by opinion? Like, that's where it comes from.
Yeah, I would say so. And again, not a perfect science. We're still learning more about it. But yeah, I would say, it is definitely, a perception. I think once that message of, and I should say, as an aside, I'm talking about chronic pain, so not like stepping on a Lego type pain, and also pain that's not associated with distinct pathology and like genetic vulnerabilities, because there's lots of things that can cause, torn rotator cuff can cause pain different than, say, the pain that people who suffer from fibromyalgia have. Very, very different. So I'm talking more about like that chronic greater than 3 months. We've healed the tissue per se, from the damage. There's nothing structural there, but we're still experiencing pain symptoms. So again, not no pathologies or genetic vulnerabilities. But yeah, I think the brain being so complicated, because it has to, like, once it gets that danger message, the brain has to say, okay, how dangerous is this? How do we perceive this danger? How dangerous is this really, right? This, in order to do that, it needs to draw on a bunch of different things, like all credible information coming in, previous exposures, cultural influences, knowledge, other sensory clues, tons of other things. Like, it's endless, the list. And there's lots of things that make people more vulnerable to experiencing pain. I should say there's modifiable risk factors for any type of chronic pain. And so we see people who experience these risk factors tend to perceive pain for longer. It's it's louder in amplitude, it's stronger. They hear, the brain senses that the pain is more severe than what an MRI or any tissue damage would say.
Right. Yeah, and I mean, it's very curious how that sort of pans out, because just, thinking about it again from a non-expert or experiential perspective, you'd think that like when you're in a dangerous situation, that's when you would want to feel the least amount of pain, right? Because that's going to distract you and keep you from being able to survive, right? You'd think that like the adrenaline would sort of put you in a position where you can fight or flee or whatever, you need to do what you need to do and not feel pain at that point, because it's compromising your safety, right? Whereas and then when you're in a safe position, it's more likely to be like, okay, well, now I'm safe and I can see what's going on internally, right? Not see, but like, perceive what's happening inside. But that's, as what you're saying, is that's not what happens, right? What happens is when there's danger, people will feel the pain, and when people are feeling safe, that's when it seems to go away, or it's at least lessened, right? So that's it. That's very interesting. It's a strange connection.
It is, and I think it's interesting what you mentioned there about what was the fight or flight response, right? Because we as humans need that. It's life-saving, right? We need to have that. For example, you're walking in a forest and you see a bear, right? You immediately get the release of all the stress hormones saying, fight, flee, freeze, right? And we need to have the ability to do that. And all animals do that. But the interesting thing about humans is that, and again, this is from a great book called Why Zebras Don't Get Ulcers. It's looking at, like animals like zebras, say, for example, need to run away from a threat, but their threat is episodic. It doesn't happen very often. When it happens, you need to get away really, really fast. As humans, we have the exact same response, but our stressors are chronic, right? So it is happening over and over and over again. So it's not like, a bear is chasing us every so often. That bear is chasing people with 21st century stressors over and over and over again. So that part of the part of your brain, that hypothalamic pituitary adrenal axis that's releasing adrenaline, is nonstop being activated. And so that changes the system from being life-saving to maladaptive and health damaging when you have constant high levels of stress hormones. And there's been phenomenal research from the States taking a look at people who are more sensitive to that repeated stress activation. Children, are vulnerable populations, lower socioeconomic status, people with mental health conditions like depression and anxiety. And they affect your immune system, and they affect our risk of other diseases, not just pain. But we know that system releases immense amounts of inflammation as life-saving, right? Because the body is prepping for tissue damage from this bear that's not there. But we get inflammation still coursing through our body, and that produces pain.
Right. And in the modern world, it's like these threats are, I don't know if mental is the correct, or psychological is necessarily the correct way of thinking about it, but it's more psychological than physical at the time, because it's like, well, for example, like now I'm in a room, I'm, by myself, there's no physical threat to me, but internally I could be tremendously stressed about work and friends and, family and all those kinds of things. And like thinking about that on a continuous basis, and, then really getting stuck there. And you can do that all day, right? And to a large degree, I've noticed that like it feels real, right? It feels like the threat is real and immediate, right? Well, it is real and it isn't real, I guess, right? Because it's like it's real in the sense of it's real to you in that moment.
Correct.
But it's not real in the sense of like you're not really in danger, right? It just feels like you're in danger, or you're imagining that there is a danger present that isn't necessarily... I mean, it's a really strange line, right, between what's real and what's not real. Not that it's like, it's kind of hard to talk about, because like psychological phenomenon are real for the person who's experiencing it, but they don't have to be true, I suppose, is the way maybe to think about it, where it's like, yeah, I mean, those things might be true. There might be all these stresses with your friends or your family or whatever, or your work, but is it real in the sense of like it's a real threat to you right now? And it's like, not really. You're just trying to problem solve it in your head, and during that process, your body kind of perceives that as it's happening now, right? And that's the anxiety and whatever that comes with it. And then, yeah, I mean, you do that long enough and you just break yourself. And it's terrible.
Absolutely. And I think, sorry.
Yeah. No, go for it.
I was just going to say the optimistic side of that is, you know, yes, the tissue damaging threat is not there. There's no bear literally chasing you. So is there a way to unlearn this learned response to stress, right? I mean, your body is going to biologically produce this. This is hormones, right? You can't stop that from happening. But can you unlearn some of the behaviors that kind of push people into that state of heightened, you know, anxiety and fear? And is there a threat? And I mean, we know there's things that predispose people to having chronic pain, and that heightened, you know, level of adrenaline and inflammation and stuff like that. So can we work on these modifiable risk factors, and what can we do to help people, you know, empower themselves? I mean, there's lots of unmodifiable risk factors. I mean, stress is one of them. It was, of course, it's not modifiable. If it was modifiable, it wouldn't be stress. But there's lots of things that we can do and try to do to help people and help communities, because it definitely, again, over this pandemic has been such a huge, huge thing that I've seen, and just hearing from patients, and realizing that it's so much more than just, you know, ow, I stubbed my toe.
Yeah, no, for sure. And it's also like, you know, I've seen it in people who have like panic disorder or who suffer from like panic attacks, right? I think that's a nice, clear example of how your mind essentially creates this terror of reality that it's very real when it's happening, right? And then there are these processes that you can learn or be taught to do, and there's lots of different kinds in terms of like how to approach it. And I guess it depends on the person, what they like and what works best for them, whether it's, you know, CBT or meditation or exposure therapy or all kinds of things, or usually a combination of many things and medications and things like that as well, where you sort of can teach yourself that you can respond differently to the thoughts that you're having or to the perceptions or the experiences. And it's not easy, and it takes a lot out of you, right? Because it doesn't just go away. And unfortunately for those people, that it's a very rough thing to go through, but people can do it, right? And so there is this ability to like modify your risk factors in terms of, you can't, you know, change your sort of structural biology, the way it's sort of primed and set up originally, but there's ways of like navigating what you do with it, right? And similarly, you can't really avoid stress in life, but you can figure out like a balance of like how much stress is a reasonable amount to put yourself through, and what's the cost to that. You know, do you give yourself like adequate rest and recovery time, and you know, to avoid like burnout and all kinds of things? Do you need to change jobs, or do you need to go for therapy, or do you need to exercise more, or like all these things that, you know, people can and do to make changes, right? And people see results, right? Not quickly, but often, right?
Absolutely.
So when someone comes to you, right, and they're like, I have this chronic pain that I've had all the tests for, and there's no pathology that suggests that there's anything wrong, what's your approach, like as a, you know, primary care physician? Like, what do you say? Like, how do we approach it from there?
Yeah, so I mean, we talk a lot about, you know, kind of proactive and reactive strategies for pain. I mean, the patient comes in and has pain. We do want to do things like pretty quickly to try and decrease pain, whether that be, like, say, for example, in my world, I see a lot of, again, I do a lot of things like cortisone injections and stuff like that to bring pain down fairly quickly. I mean, that's not a cure at all, but that can help break the pain cycle enough to start on some of the ways to modify the chronic pain cycle.
Right.
So that's kind of the reactionary, like, we're reacting to pain, let's do something. And so a lot of times people kind of jump on, like, I want to take medication, what can I do now? I need something to be done quickly. And like you were saying, it's not a quick thing to reverse, but if we can do something fairly quick to bring some pain relief a little bit, that can usually make some of the other things a lot easier to do. Say, for example, the most important thing is getting good quality sleep. Like, insomnia and pain are so intimately connected. One causes the other and vice versa. So if we can get pain down so people can have good restorative sleep and good quality sleep, that's one of the first things I tend to focus on, because it can be, it's something simple. It's something that a lot of people don't recognize as a big contributor to pain, and it is the biggest contributor to pain, to chronic pain. And it's something that most people, despite because honestly, a lot of things we do to help with pain are expensive. People don't have coverage for it. So if we notice that a lot of people who are in pain tend to be, people of more lower socioeconomic status, marginalized populations. So things like improving sleep quality is something that we can try and do fairly simply and inexpensively, limiting your screen time, making sure you have, proper dark curtains, or eye mask or whatever, and making sure you have, good, like, I'm in bed at 10, I'm up at 6, proper, no naps, very structured time, limiting nicotine and alcohol and caffeine, stuff like that. And then, as I kind of build the patient relationship, if they want to delve into more of the other things like mental health issues, stressors, PTSD, stuff like that, then we keep that open. I mean, unfortunately, it's tough. You get a lot of pushback from people, but I just keep telling people, like, what can go right? Like, you might not solve the problem, but you really can't waste your time trying to be a healthier, fitter person. Yeah. I mean, I think a lot of it does come down to kind of the society that we live in that kind of promotes stress and work hard, push hard, like, don't talk about it, anything like that. But definitely kind of starting that conversation. Yeah. And it's interesting how many people, if they're open to hearing what you have to say, and a lot of times it is my veterans, when they recognize it and I say, like, tell me about the last time your back pain was flared up. And they're like, for example, someone was like, my mom was really sick in the hospital. Like, what else is going on? And then you recognize that there's this trigger here. Right? So, okay, that's a really big life stressor going on. Of course, your inflammatory system is going to be so heightened. Or if somebody suffers from depression, recognizing that the biological vulnerability, telling them, like, the biological vulnerability that you have because you suffer from depression means that you don't recover from these stressors well. So it's once that's recognized, then we can build from that and see what we can do. Like, how can we modify these things? There's a really great quote, and it's about public health, and it's kind of if there are 100 people and they all drink from a well and 98 of them get sick, you can either give out gobs and gobs of medication to try and cure them from their illness from drinking out of this well, or you can turn around, walk over, and go, "What is in this damn well?" Right? And so fix it from there. Yeah. So best thing to do is try and improve, like, general health as opposed to fixing these specific issues of the tissues.
I like that. Issues of the tissues.
Issues of the tissues. Not my quote. That's a great quote from a wonderful author named Todd Hargrove.
Nice. It's a good one.
It is good. But
that makes sense, right? It's symptom versus causal treatment. And, it's also I imagine, people come in and they're often desperate, right? Because chronic pain can do that to you. And so that they'll want to come in, and particularly if they've been avoiding seeking help for it for a long time for all sorts of reasons, they finally come in and they're like, I just want something to make this go away. And, as you say, it's not that simple. I mean, you could give them like prescription meds, but that's a symptom treatment, and, that might end up doing more damage than it does good if it's the only thing that's being done, right? Hence the sort of opioid crisis of the last few decades.
Yeah. And I think it's hard because, my mentor in family practice, who's retired now, but I remember her telling me she remembers the day that a pharmaceutical rep came into her office in the 80s and said, we have the best drug. Like, it's going to help all your patients with pain. And like most doctors, like, if we can help patients with pain, because pain is so difficult to treat, if we hear this, we're like, that's wonderful. Great medication for pain. It's not addictive. It's wonderful. It's really going to help your patients. Yay. It's called oxycodone. Yeah. Right. And so, oh my God, now we look back and we're like, how could you be so stupid? But like,
right.
He didn't know. Right?
That was the science at the time.
It's exactly. And this is why science evolves and changes. And that's why we're learning all about new stuff about pain in the last couple of years, right? Like a big study just came out in 2019 about, insomnia and sleep that finally showed parts of the brain that don't work well when we aren't sleeping properly, and so this is just in 2019 they realized that sleep deprivation makes, suppresses the activity that fine-tune pain experiences. So we get, like, if you don't sleep, you get this loud pain alarm and you have less ability to turn it off. And it's, again, that just came out in 2019. So we're learning so much about it.
Yeah. And it's also, a weird part of science is the progression of science, at least, is that, like, real scientists, they try to prove old theories wrong to make them better, right? And that it's okay to, there is the unfortunate consequence of, like, because we don't know everything as the human race or science, let's say, we don't know everything. And so everyone's sort of like doing their best they can, aside from any sort of like nefarious activities that happen for money, which is definitely a huge problem. But let's give people the benefit of the doubt to say that, people are trying to help people, right? And advance science and advance medicine and things like that. And sometimes, mistakes or overlooking things or just not knowing has a huge cost. And that's very unfortunate. But it does happen. And then, the right approach would not to just be abandon everything and be like, well, all science and all medicine sucks. Forget about all that shit. It's like, no, well, now we have this problem. How do we deal with it? Right. So like now we have all these people who are addicted to opiates, possibly for years. How do we deal with it? Right. Yeah. That would be the ideal way of approaching it. I don't know if people get that kind of treatment all the time, but that's sort of physician dependent, right? And it is. But just back to the idea of sleep, it's like we do underestimate sleep so much, and I'm not even sure why. It's such a... you just need to look around to know that everything that lives pretty much sleeps. Right. And then for us humans to come along and to just be like, nah, I don't need sleep. It's fine. I can live on 4 hours or whatever. It's like, you what are you doing? How could you think that that's possibly just fine to be endlessly tired and fatigued and just, it's the worst. I hate feeling like I'm the kind of person who, if I don't get like 7, 8 hours, like the day sucks for me. And if it happens more than like 2 or 3 days in a row, then I'm fucked, right? Until I get that sleep. And other people aren't like that. They can, I don't know if it's something with willpower or whatever, that they can push through that for like years. It comes at a cost, that's for sure. But it is amazing how much we underestimate sleep, and it's not even clear why we do that. I guess it's because, from our sort of like mental perspective, it's like, well, it doesn't seem to do anything. We don't immediately observe the effects of it except feeling better and knowing that we need it when we get tired, right? We have this huge draw to go to sleep, which is also an interesting thing. Like people who, get lost in the cold and eventually they get so tired that they fall asleep and they know that they're not going to wake up, but that pull to sleep is so strong that people do it, right?
Yeah.
Which is very curious, because you'd think that your body would just be like, no, we need to use every energy resource available until it's absolutely nothing left. But that's not quite how it goes, right?
Yeah. Well, in that case, like when you're getting like hypothermia, you are shutting down to preserve, right?
Right.
So shutting everything down to preserve. But yeah, like insomnia, like it's not generally fatal because we've got all kinds of these self-preservation mechanisms that will kick in.
Yeah.
But what is the thing I remember learning? Like a poison at a non-fatal dosage is still poisonous.
Yeah.
Again, that's not my quote. I wish I was that smart. But like there's like sleep deprivation is dangerous stuff. Like it causes migraines and makes you vulnerable to infections. It wrecks your mood, wrecks it, and makes you sick in the long term as well too. Like you were saying, like you don't recognize it right away, but things like insulin resistance, type 2 diabetes, cardiovascular disease, like there is association, all of these things. And I remember when I was in my medical training, and when you're in your residency, you have to do call, and that's in the hospital, and you're up for 26 plus 2 hours. It's union mandated, so it's 28 hours you're awake. And when you're driving home, like they've done studies looking at medical residents trying to drive home, you're basically driving under the influence, the same as a drunk driver would be.
Yeah, it's so crazy that they make students do this.
Yeah, we're trying to do surgery. I mean, it's interesting because we actually don't like screw up as much as people thought we would, because you go into this fight or flight, overdrive response, but over time that just becomes like, again, you get sick, you're cranky, it's chronic pain.
Is there any benefit to it?
To insomnia?
No, to these like 24 or 30 hour shifts.
Yeah, it's interesting. The thought is patient handover. So when the most dangerous time in the hospital is when one doctor is changing to another doctor, and the doctors have to communicate with each other about patients. That's called patient handover, when you're like, I'm going to tell you about Mrs. Blah, blah, blah in bed number 2. That's the most dangerous time because it's human, right? Human transfer of information is not, we're not great at it. And so they try to have the longest amount of time with one doctor possible and then hand over. That, I think, is the theory behind why. There's also the like social idea of, well, this is how it was back in my day. You have to all suffer, and this is what residency is like. It's always fun, right? Like, I had to go through this back in my day.
Yeah.
But there's definitely been a change, at least in the medical culture, over especially this pandemic, when medical doctors are now the highest rate of suicide out of any career. Like, we surpassed the veterinarians, and we were like, go us. But it's not just insomnia and stuff like that. It relates to burnout and moral fatigue and stuff like that, compassion fatigue and whatnot. Yeah. But it's a strange thing.
I've always found it very strange having friends who have done it, and I'm like, why are they doing this to you? Like, I can't see a benefit in other than, the people who are doing it to you get the benefit of it, but it's like, there's for sure that, I mean, they do it in lots of professions, like when people do articling for like law or accounting or all kinds of stuff, and people, do like 18-hour days, 7 days a week, and it's like, why? This is so insane, right? And, I don't understand it, because I'm the kind of person who goes like, if I let's say if I went through medical school and I had to do that, and then I reached the point of like a senior person who sort of now has junior people, I wouldn't be like, oh, I went through it, so you have to go through it. I'd be like, no, I did it and it sucked. How can I make it better for you that you don't have to suffer like I did, right? But that's not how people approach it. They're like, no, it's some sort of test of, it's like an initiation routine or something like that, right? Very strange.
I think there is, unfortunately, a part of it is staffing the hospital. You know, hospitals are overflowing with people, and there just there aren't enough people to work. And so it's trying to get enough people working, and then people need to have time off after they've worked and stuff like that. So that's a real struggle. I mean, we have a shortage of all types of all types of healthcare workers. And I mean, we see very similar things in shift workers as well, too. Like the people who work, like our nursing staff who work 12-hour shifts, and they do like 4 nights, and then they take a break, and then they do 4 days, and it kind of flip-flops back around, and so you don't get that good regular sleep cycle. We see that and anybody who works overnight really it throws it all off.
It's so crazy, and I feel for anyone who has to do it, and some people like it. I don't know that it's most. I think you could probably get into a routine and sort of learn how to enjoy it more than just suffer through it. But and there's also something quite special about being awake at night when no one else is, right? But it does come at a cost if you do it too much, right? But so the other thing that I wanted to chat to you about today that we had sort of mentioned was the connection between trauma and pain, right? So what, I mean, I know it's a complicated question, but like, what's the sort of general idea of how those two are connected together?
Yeah, I think it's related to what we talked about already, of that feeling of like threat hypervigilance.
Right.
That's kind of a main driver for pain. Sorry.
No, go for it.
And that chronic trauma over time becomes, again, like a conditioned behavior as you're kind of constantly on high alert. And similar to what we were talking about, that threat of the bear in the forest. But what we now see are the threats of the bear now is prior trauma, physical, emotional, sexual abuse, neglect, parental illness, substance dependence, domestic violence, stuff like that requires the person involved to be at a level of hypervigilance. And we know that is, again, like I was saying, a main driver for things like for chronic pain, because you have to have that. Your body is thinking it needs to constantly be on high alert, but happening for so long, over and over and over and over again, just activating that system over and over again as like, the bear comes home with you all the time. You kind of have this repeated, again, just nonstop stress activation. And I think that trauma, and again, so like for example, like if you have something horrific that happens to you, I just lost your video.
Oh, I'm still around.
Okay.
Might come back.
If you have a trauma that happened to you, and you can kind of picture like person, place, thing, everything that happened, I think our brain responds similarly to that. Like for example, like what's a good example? Oh, like when you blush, like you get the blood vessels are all dilate, it's instantaneous physical change. It betrays what you're feeling. When it happens, you can't control it. I think that's really important. Like, for example, I always blush when so and so walks in the room. Like, you can't control that. Even when it increases your embarrassment, you still can't control it. You can't stop it. So I think you can extrapolate from like, I always blush in this situation to I always hurt in this situation because of what had happened before. That like existence of the former suggests that pain can be a conditioned response to trauma. Like, and we feel similar symptoms. For example, Like my patient whose mother died, she was a military. She served like 2 tours in Iraq, and again, she gave me permission. I'm not going to give any details, but she was very, very vocal about her experiences. She was feeling, she had like immense like back pain and like a back injury when she was in Iraq, and it really hampered her ability to do her job, and she felt guilty about that. And she was feeling same symptoms that would flare up identical when her mom was sick. And it's not like her back is re-injured. Her back is fine.
Right.
Tissue is fine. But she's experiencing similar reactions to what was happening in Iraq that caused the tissue trauma to begin with, right? Feelings of guilt, depression, and that reaction. Again, it's that opinion. The brain's going, oh, we're back in Iraq. Oh, we're feeling guilt. Oh, we're not feeling so good. Oh, then we should feel pain again, right? Because it remembers, right? We're in this situation again. I always bluster in this situation. I always feel pain in this situation. Here we go again. Yeah. So, yeah,
cycles.
From trauma comes that.
Right. Yeah, and there's also, as we had sort of spoken just before we started, about this emerging literature of how trauma gets stored in the body, so to speak, or there's that book, how the body keeps score.
The body keeps the score.
The body keeps the score, about how repressed emotions or traumas or bits of your personality that you sort of aren't prepared to face yet, or whatever it may be, which sort of result from trauma or traumatic like events, that somehow are still contained in your physical body in different parts, right? I mean, it could be your hands or your feet or your chest or your back or your stomach or whatever. And it's weird because there's no exact like physiological reason for it to be that way, at least to my knowledge, right? But it is obviously there, right? Like there's tons of evidence and studies that have shown it to be true, and that people can actually internally, usually with guidance and things like that, they can place it inside of themselves, right? You can do like a meditative body scan, and you get this sensation when you sort of focus your attention on a particular part of your body, and certain memories might come up, and emotions and feelings that are connected in some way that you sort of activate when you place your attention there, and you can resolve them and work through them like that, and whatever it is. But it also makes sense that you could be feeling that pain there, and it's actually not as far off from like other emotionally physiological responses. Like when you get like butterflies in your stomach, it's like it feels like something's happening, right? Like in your abdomen area, or I don't know, that was one example. Or like, you feel like emotion from your chest, like from your heart, and people say they feel love in their chest, not so much in their head. And that's also interesting. And so it totally makes sense to me that trauma can be directly linked to like, chronic like body pain, right? Issues with the tissues. No issues with the tissues, but, some sort of experience of it. I can't think of a rhyme with experience, but, or opinions. Yeah. Opinions is also difficult to rhyme with. We'll think of something.
Same with perception. We'll figure something out.
Very, very long, tricky words. Anyway, but so anyway, what were you going to say?
No, I was just saying the Body Keeps the Score book was fascinating. It's pretty controversial because there are some people who think,
Sure.
Again, like we had talked about, it's very, very individual, just like the pain experience. The recovery from it and the management plan is very individual, because there are some people, like as in the book, and the book makes reference to it, that can re-trigger and actually set people back if it's too soon to be kind of going deep into kind of reliving traumas and stuff like that. But yeah, I totally agree. And I think the biggest thing that I try and convey to patients is that, because everyone always says, are you saying it's in my head? And it's kind of hard to say no, because it's not like, yeah, it 100%
Yeah.
is in your head, right? Your brain controls your reality, right? Your
Yeah.
brain is what's producing these hormones. Like, of course it's in your head, but it's very real. Like you're saying,
Yeah.
butterflies in your stomach. Like, that's a real sensation. Your heart rate's going to go up when you're nervous. Like, that's real. You can see the number going up if you have a heart rate monitor on. That's a real response. That's not fake. Nobody's thinking you're faking anything. But it's
Yeah.
tough when people want, I shouldn't say people want, but like people like to see something structurally damaged.
Right.
There's comfort in that because then there's a very real socially acceptable diagnosis. There's limited stigma. And also you're like, great, here's something torn, cracked, or broken. We will fix it. It's hard to say there's nothing torn, cracked, or broken. You have a functional, very real cause of your pain, and here are some of the ways to help it.
Right.
It's hard because people don't want the pep talks and platitudes or general things. They want specifics. But like general answers do matter, like exercise, sleep hygiene, quit smoking, but those things are all difficult, active things that people have to do, and they have to really want to do it.
And they're not quick fixes.
It's not quick. It's hard because you have to, you're doing a deep dive into a lot of your psychology, and that's a hard thing to do, and a lot of people want to avoid that. But the people I've been able to yell at and say, like, this is what you need to do. Yeah. People who've responded and have been like, yes. You either get people who are like, no, I want quick fix, boom. Or you get the people who go, all right, and they're empowered by it.
Right.
And that is when you can really see improvement. And that's when it's exciting.
Yeah. And when people are ready for it, right? When
they're ready for it, right?
Yeah.
And I think a big part, again, thinking about the pandemic as well, a huge part, a modifiable risk factor for pain is social isolation. When you don't have a good support group that makes you feel safe, you don't have love and support in your life, that is, another predictor of increased feelings of pain.
Yeah.
And like giving support is just as good as getting it. So being involved in the community, people who are able to get out and volunteer, you have more to worry about and less to do when you're lonely, right?
Yeah.
So people who get out and are involved and do simple things like, volunteer at the hospital, or wherever they can, and develop a social network, that's a huge component of it, because we weren't meant to be by ourselves, right? The
social creatures.
The poor zebra who's off by himself without his tribe is the one that's going to get killed first, right?
Yeah.
So you need to be a part of a tribe.
Absolutely.
Sure.
And that's why like mutual aid groups work really well, right? For like substance use or various conditions, and it's where people can go and give support and get support with no ulterior motives. There's no money, there's no business, there's no status, there's none of that. It's just people helping each other with, coming from similar experiences and similar places, and being able to be like, we're in this together, right? We work as a group, as a unit, and anyone's welcome, just about, I suppose, unless you're a real dickhead. But maybe there's a group for those people too. You just need to find your crew.
You just gotta find it. Exactly.
And it's true. And COVID has really, unfortunately, what it's done, I think. I mean, I've experienced it myself, where it's like you don't even realize how slow change happens and how quickly you adapt to it. But it's not necessarily a good adaptation. It's like just a survival adaptation, right? So with COVID and when everything started, it was like, everyone's just you got to stay by yourself or within your family unit or something like that. And you just got to sit it out, right? That's just what we had to do for a long time. And then you just do it, and you miss your friends or your family or whatever it is. And, people sort of make different choices about things, and that's okay. But ultimately, it's like when you do it for too long, then that becomes your new normal, right? And then that it's just how you do things. And you're like, I don't have any social engagements, or maybe one a month or something like that, right? or if you're lucky, it depends where you live, I suppose. But it becomes a new normal, and then all of a sudden, you go back to a group setting for something, right? Some function or some night out or something like that, and then you connect with people, and you're like, oh my God, this is what things used to be like, and this is, feels great. Just being there. Like, it doesn't even have to have a reason. Like, just going to a restaurant and being around other humans is such a huge deal, right? And so we did have to go through this, like, rough patch of, I guess it's like you don't know what you've got until it's gone, right? We didn't know how much we needed each other until we weren't allowed to be with each other. And then now we're like, oh, okay, it's time to kick that shit back up and feel good again, right? And return to being human, and having good relationships.
Yeah, good relationships, and that community of that network of support, whatever that looks like, right? Like, it doesn't.
Yeah, I mean, it could be one person.
Exactly, and it doesn't have to be, like you're saying, it doesn't have to be in person. There's huge value to online friends, and but having somebody, like, so you're not having somebody there is, it's just so key. And I think it's tough because we have not, most of us, thankfully, have not had to live, and like you were saying, in a time of war or
famine,
scarcity. Famine, exactly. We've lived in land of plenty, and we are so privileged to be doing that. But I think, we're privileged to be doing that, but it's we still have to respect the fact that it's really hard when that changes. It will be hard. It was hard, right, for everyone when that flipped. And people are like, oh, we still have it so good. We still have it. Yeah, we do have it so good. But, give yourself a little bit of that corny phrase. Give yourself some grace. Because it was a massive change, right?
Yeah.
And so talking to people who've been through the wars, and who've been through times of struggle, my grandmother-in-law, still, keeps all her tea bags and stuff because she remembers what it was like when they didn't have that, right? And
right.
So keeping yourself humble, but also still recognizing that this was hard.
Yeah.
We've never had to go through this before. And when you have to go through something new, it's going to be a little tough.
Yeah. And the other thing about COVID, which was, I mean, interesting, we will use the word interesting to say, is that, like, particularly in the beginning, where it wasn't exactly clear what we were dealing with for the first few weeks or something like that. And essentially everyone felt at risk of dying, right? Because there was just no information about who's more or less at risk, what the mortality rate is, what the long-term consequences are. And so it doesn't matter how much money you had to access medical treatment. I mean, it makes a difference, obviously, but even given that, there was this sense of, like, any one of us, no matter how old or in what health condition, we could die from this thing that just came out of nowhere, that no one expected or foresaw. And it was a really strange time to be around, and there was so much fear around, understandably, right? Because everyone felt like they might die if they catch it. And some people still feel like that, and, that's okay and whatever. But, I mean, so there was that interesting point in the beginning where I noticed, where I was like, everyone just, I mean, I suppose there's exceptions, and there's also the people who are like, it's not real or stuff like that, and whatever, it's not particularly relevant. But there was this, like, thing that surpassed, any sort of, like, socioeconomic system of, like, everyone is at risk. And now it didn't turn out to be that way exactly, but it certainly felt like it before anyone knew anything about it, right? Now things are obviously different, and there's science and studies, and, millions of people have had it and been okay, and some haven't, and, but there's information now, so we can make educated decisions about it, and there's treatment protocols and all kinds of things that we didn't have 18 months ago. And so it was, and so I think that it certainly gave people, like, it's not exactly like a near-death experience, but it's something like that, I think, where it was this sense of, like, reality is not what you think it is anymore, right? Everyone had their 5-year plans and their 10-year plans, and then the universe was like, guess what? You don't get to make these decisions all the time, and you might be at risk. And it's scary, you know, and I think it's a big reality check. And I think a lot of good can come from it too, you know, in terms of people realizing what's a priority for them, you know, like whether they prioritize work or relationships or, you know, like money or things like that. It just sort of forced everyone to reevaluate their lives, which is not a fun thing to do, but it can be good for you if you take it in that way, right? Not to obviously diminish any of the terrible things that have happened because of COVID, which is obvious everywhere. But there is something that happens through like really bad times, which is that you then start to appreciate the good and other people, and you can really sort of like hone in on that if you can. It's that positive attitude you were talking about, you know?
Well, I think that's really important, you know, and I think what can come out of it, you know, we've seen studies for people who survived concentration camps, and you kind of go one direction or the other. I mean, obviously huge gray areas, but like survival guilt versus survivor, you know, I've been given a second chance at life, right?
Yeah, gratitude.
So gratitude, exactly. I mean, obviously huge gray areas there. I'm making it extremely simplistic, but yeah, I think it's going to be interesting to see what happens as we come out, hopefully, from this. And I hope from an individual standpoint, for sure, people have reevaluated. But I really hope that systems get reevaluated and we recognize how disproportionately affected some people in our communities were from COVID. You know, women, stay-at-home moms, low socioeconomic status people who did not have the luxury of staying at home, where everyone was like, oh, this sucks, I have to stay home. It's like, well, a lot of people couldn't afford to do that.
Yeah. If you don't work, you don't eat.
Exactly. And so I think looking at, again, coming back to the analogy of if 100 people drink from the well, stop giving them antibiotics when they get sick, look at the stupid well and see what is causing this, right? You know?
Right.
Like, it's so important to look at the bigger picture of that. And yeah, for sure.
Yeah. And we're also seeing it, I mean, we don't have to go down the vaccine, you know, rabbit hole, but we're also even seeing it with that, about how some people, you know, the sort of various marginalized groups are much more likely to not want to get the vaccine, and they're not going to be subsequently ostracized when these vaccine passports are going to be implemented. And that's going to create a huge problem, because you're going to have this big percentage of people that are disproportionately, that has a disproportionately large percentage in the sort of unvaccinated group that are now going to be excluded from society, which is a mental thing that's happening. And I don't understand it, but it's we'll see what happens from that, you know?
I think it's so complex. I mean, of course, you're going to have the white privileged people who, you know, it's the same people who thought the vaccines cause autism, where it's like anti-vax, vaccine deniers, that's a privilege, right? Like, you're so privileged that you can be like, I'm not vaccinating my kid. Like, that's ridiculous. But then you also have the other side of things where these marginalized populations, lower SES, or indigenous communities who have a very real, justified suspicion of the healthcare industry, of science, of the government.
Absolutely.
And absolutely real. And I was watching this phenomenal documentary, which I don't think I can say what it is because I'm a judge for the Ontario International Film Festival, and it was one of the film festival films, and it was just phenomenal. But anyway, it's kind of a global thing. My husband and I were talking about it, and it was about Indigenous populations. And the whole idea, and my husband did medical school in Australia. I did medical school here. And we learned very similar things about the Indigenous population in both Canada and Australia, is that when we as non-Indigenous people think of the hospital, we think of, this is where I go to get better. Indigenous people, huge generalization, but have a mindset of, this is where I go to die. Because they remember, like, residential schools on the reserve, they would have to ask permission to go, when they were sick, to go to the hospital from the guards. Like, they just had, horrific experiences with the healthcare system. So there's a very justified suspicion from these groups of people. And so hence the reason why low vaccination rates. And so it's trying to dig through that from a public health standpoint and recognizing that this is not just like, I'm a privileged anti-vaxxer. This comes from a very deep-rooted systemic problem that is going to be really hard to, I don't think resolve is the right word, because it goes so deep, and to manage and to try and gain that trust back. It's
never mind the
fascinating
experiments like the Tuskegee trials in America, and and that was related to a vaccine, right? I mean,
absolutely,
no shit, people don't trust the government.
Yeah, exactly. So I have no respect for people who are like, I come from a very privileged white upper socioeconomic status who've not gone through this. Like, that's just ridiculousness. But when you've come from a population that has seen and been through and has generational trauma from this, then that requires the respect and the ears to listen, and that's where trust comes from. And it's the same thing that comes right back to, we're talking about how I deal with, that sounds horrible, how I chat with and converse with patients of mine that I see with chronic pain, right?
Yeah.
Developing that trust.
Yeah.
That went on a tangent.
I have no idea about what the right thing to do is. I mean, there's so much debate, and it's such an emotional topic, vaccines at the moment. And I'm just like, I don't know. Like, people ask me what I think about things, and I'm like, honestly, I don't have enough information to make any sort of educated, to give you an educated answer. And thank God I'm not in a position to make decisions about these things, because I wouldn't know what to do, because it's an impossible choice that people have to make. And I feel bad for the decision makers, and, the consequences of their decisions will come to fruition regardless of what happens. And it might be good, it might not be good. And, I'm hesitant. I'm very hesitant about the sort of vaccine passport thing. I mean, I get why people want it, and, people want to get back to living, and they're like, well, I'm vaccinated and I don't want the unvaccinated people to put me at risk and to stop me from getting back to normal. But I'm also like, yeah, but the other side, like, you can't just get rid of them and ostracize them from a community, even if it's a relatively small percentage. Like, it doesn't work that way. And with international travel being as prolific as it is, it's like, unless the whole world is vaccinated, then you're going to get, millions of people in all sorts of third world countries that are going to be unvaccinated, that are going to be traveling. And so it's like, why do this to people? But nevertheless, it's good that I'm not making these decisions.
It's tricky. It's so tricky, right? I think a vaccine passport is not a new thing, right? Like, no. I had to be vaccinated to get into medical school. I had to show proof that I had yellow fever vaccine before I could enter into Kenya when I went. But yeah, I remember having a discussion about somebody was saying, oh, everyone at the Olympics, why aren't they all vaccinated? They should have all been vaccinated and stuff like that. And I was like, half the countries don't have access to the vaccine yet because America bought it all. Right? Like, these poor third world countries don't even have access yet. I mean, it's getting there. We're getting there. But, like, eventually, you can't demand vaccine status from a third world country that has yet to get the vaccine. And then that, again, huge public health implications for that. Yeah. For sure. I mean,
and also, like, mandated vaccines is ethically problematic.
It's tough, right? I think
it's not clear cut, but it's
not
tough.
Clear cut. And I think, I could debate with people. I mean, I'm a doctor. Everyone knows my status. Of course, I'm going to vaccinate everyone. But vaccine deniers, and I don't really have much patience for. It's the vaccine hesitant that I love to talk to. Yeah. Because they're the ones that I will sit with you for an hour and let's talk about what you're worried about. Yeah. Because for them, it's fear. For them, it's not anger. Like, anti-vaxxers are angry. It's like, angry is a secondary emotion. I can't deal with that. Yeah. When it's fear and lack of trust, Like, let's have that conversation to talk about that. And it's the same with anything in medicine. What we're taught to do is to ask somebody, like, they come in and they have all these symptoms.
Right.
Well, and we ask them, well, what are you worried about? Because there's usually something that they're too scared to tell you because they're worried they'll be judged. But like, no, let's talk about it so we can go
resolve
through it together.
Things. Yeah.
Exactly.
No, for sure. And it's not so clear cut. And I think unfortunately, people who are hesitant to get the COVID vaccine are unfortunately grouped in with the sort of like anti-vax group.
Yeah.
Which are the sort of loud, angry people. And not all of them are like that. You know, it's just the loud ones that make the most noise and give the group a bad name, as it is with all groups, right? I mean,
exactly.
You get the crazies that just give everyone a bad name for it, and it's not an easy. There's no easy answers, and you know, I have huge empathy for everyone involved, and I don't like the anger that comes from both sides, because you also get the sort of pro-vax people that are so angry about the people who are hesitant to get it, and you know, like wishing terrible things on them, and even wishing death. And it's insane that we've reached this point where people are like, you know, I hope you die from COVID if you don't want to get the vaccine. And it's like, what's wrong with you?
Or and vice versa,
you know?
right? Like, I hope you
or
die
like, I hope the
vaccinated.
vaccine kills you. Yeah. It's like, what's wrong with you?
Blows my mind.
These are real people, you know, and if you met them in the street, or if they're your family member, you're not going to have that opinion, right? We have the privilege of hiding behind our screens when we do that, and anonymity to be able to just voice our anger over the internet and make a ruckus and upset people. But that's been, I think, the most troubling for me, is the sort of level of rage that people have on all sides, of just like wishing harm. And it's like, that's a really dangerous thought that people have. And if lots of people have it, you could end up in a very bad place.
I think it's scary when somebody's, again, we talk about like anger is a secondary emotion, right? So it usually means that there's a deep-rooted primary cause for it, and it's usually fear and lack of understanding, sadness, right? And when our like lizard brain gets so overwhelmed and doesn't understand, people either ask questions to figure out more. That's the majority of the population. Or lizard brain kicks in and goes, I don't understand, I ain't gonna rage about it.
Yeah,
and they
in defense.
Exactly. Yeah. And when somebody's baseline or response to, I don't understand what's going on, is anger, ooh, that's scary.
It's concerning.
Right? And usually those are the people who are making decisions.
Yeah, that's the fun part about
that's
humanity.
The fun part. Exactly.
Because
they're the loudest, and they cause a ruckus. And people don't want them to cause a ruckus, so they go, okay, sir, we'll help. Okay.
Yeah.
Right?
And they just bow to, you know, the sort of social pressure of it. It's unfortunate.
It is.
And I don't know what's to be done about it, if I'm honest, because I'm like, we're dealing with millions of humans. You can't just be like, this is what you need to do. It's like, that's not how anything works in society. You know, there's division on all things in terms of opinion about stuff. Like, that's the nature of politics, is it's like and it's unfortunate that science and medicine has become politicized, because it should be apolitical, because it's not relevant. But that's not the reality of it, because there's so many players involved, and there's so much money involved. And whenever there's money involved, things get complicated, because what's the priority anymore, you know? But that's a topic for another day. Listen, this has been a really great chat, and thank you so much for coming on. Is there anything you'd like to promote, like a site for you, if people want to, you know? Yeah. I have a
website. It's nothing crazy. It's just janetmcmordie.com. There's nothing on there except my just my face, I guess.
Yeah.
But yeah, I have a small clinical practice in Orillia, Ontario. Oh, I do a podcast with the Canadian Academy of Sport and Exercise Medicine. The Canadian governing body of sport and exercise medicine. We do a podcast. But that's all.
What's that called?
Sports injuries and stuff. So it's just called Canadian. What is it called? Oh, that's terrible. It's like common topics, and it's CASM, CASEM, is Canadian Academy of Sport and Exercise Medicine, and it's like the podcast from there. That's terrible.
Cool.
I should know what the actual title is. Hold on, let me look for it. You can edit this out because it makes me look bad. It is called.
Well, that's fine. I started off with your name wrong.
Yeah.
You know, it's a good episode for us.
The Canadian Sport Medicine Review Podcast.
All right, and that's available everywhere for people to check out?
Yeah,
right.
They can check that out. We have lots of interesting sports medicine guests.
Amazing. Well, thank you very much. I hope we do this again soon. But until then, keep well.
Awesome. You too. Thank you.
Take care. Bye.